So in our last episode of Sapio with Buck Joffrey, Neurologist Dr. John Foley took us through the diagnosis, pathophysiology, and other things related to Alzheimer's disease. He also told us about the risk factors for getting Alzheimer's disease, both avoidable and not avoidable. Now, in this episode, we're going to talk about what we can do to mitigate the risk of developing Alzheimer's disease in the first place, and even if you are genetically predisposed to it. So this is really, really important stuff. We talk about everything from saunas to supplements. We also take a look at the cutting-edge research and new therapies that might actually be able to treat Alzheimer's disease, that people already have. And remarkably, some of those treatments look like they're right around the corner. Again, this is a must listen for anyone who wants to, to live a healthy, long life, because who wants to do that without your cognitive abilities and your memories intact? It's relevant to you and probably to someone in your family who's older already and, who might be in a position where they're getting at higher risk for Alzheimer's disease. And so hopefully by listening to this show, you're going to come away with some very actionable information for you or your loved ones to play offense against this brutal disease. By the way, if you want to see what Dr. Foley is up to with this neurooptimization clinic that he mentions in the first episode, I encourage you to go check out his website for Serapro Bioscience, which is seraprobio.com. That's CEREPROBIO.com. And we'll put that in the show notes as well.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
Let's get back to that. We could go on with risks forever, right? But I think we've hit, unless you think there's something else that we should absolutely hit, most of those, and maybe kind of pivot into whether or not you have one of these genes, whatever. What are some of the things, to minimize your risk of Alzheimer's? We can sort of skip the obvious ones, I think, that we've kind of talked about, smoking, alcohol, sleep, getting adequate sleep, which you talked about. You talked about controlling your glycemic, your blood sugar, blood pressure control. I guess the other one that we've not really hit is there's a head injury risk there too, right?
Absolutely. And this whole traumatic encephalopathy thing in the football players, clearly that really accelerates your risk of going to AD.
Right. So now you're controlling some of those, that you want to try to stay away from those risks. How do I really play offense?
Okay, so offense against Alzheimer's. That's to use the football analogy, which I know you're a big fan of.
Yeah. Yeah, exactly.
There are a number of things to do playing offense. And maybe the biggest one, you have your vascular risk factors, right? Which you've got to get those under control. You can't be having LDLs at 200. That's your bad cholesterol. You can't be having a real high lipoprotein B. You can't be having uncontrolled high blood pressure. You're going to have a very hard time making headway if you don't have your vascular risk under control, including diabetes.
Along that lines, I think an important point, John, is there's like some sort of kind of, how some of these false information things get out there. But there's a lot of people who are scared of statins because they think that there's that they're going to get Alzheimer's disease from taking statins.
Yeah, that's a big problem. The benefit of statins. Now, I'm not going to say there are people that are statin intolerant and, muscle issues, or even there's a little bit of data on peripheral nerve damage with statins. And there is some cognitive, a little bit of cognitive data, but the power of getting your LDL under 100 is just huge,
Right.
And you don't, if you really don't like statins, you can use things like Repatha, right? Which, those drugs, they're expensive and they're harder to get with insurance, but that works amazingly well. But you've got to have your lipids correct, or you're not going to make much headway. So that's a general physician, aggressive physician. You want you want them to be pretty aggressive on your hemoglobin A1C, which is sort of your long-term measure of your diabetic risk and your insulin resistance. You want your blood pressure under control, and you want your lipids to be good. So those are the kind of the first tier vascular elements that are really, really important. Then you get to the power of exercise as our next thing, which is huge. I mean, for longevity things, the couch potato versus the high-level athlete at any age group has a lifetime risk of longevity that's like 4 times greater in the athlete versus the couch potato. So it's just amazingly different. It has effects on neurogenesis. So there are a number of areas of the brain where we're making new brain cells. That's not a concept that was very popular 20 years ago. The part of the hippocampus, which is the memory consolidating area of the brain, probably makes at least 700 new hippocampal neurons a day, and that's impacted by all of these factors, up or down. So exercise, neurogenesis, neuroplasticity throws off something called myokines, which are actually little bits of protein that can get up in the brain. The blood-brain barrier is permeable to them, and myokines increase production again of these neurotrophic factors, which build the support structure, brain-derived neurotrophic factor and all of that.
We just, at the end of the day, what I think is really interesting about this is that I think a lot of people don't really associate brain health with the rest of their physical health. And what you're saying, and I think what research is very clear on, is that exercise isn't just about your ability to run around. It's about your ability to think and not get dementia.
Oh, absolutely. It all goes together, Buck. The neuromuscular system is just as important as the brain as an integrated part of the whole process. And we're not really talking about a loss of muscle tissue here, like sarcopenia, which is 8% of people die of ground level falls over 70, because they can't, their type 2 muscle function fibers, the fast twitch fibers are just all atrophying on them. So, and I don't really like even using the word exercise, because really there's 3 elements to it, and all of them are really pretty darn important. You've got to be doing resistance exercise. Most people over 65 are doing 0 resistance exercise. You have to be doing baseline aerobic exercise, and you have to be doing some of the high intensity interval training. Get your heart rate really up so your lactate level goes up. Lactate crosses the blood-brain barrier. It's a fuel in the brain. It increases brain-derived neurotrophic factor. Lactate increases your executive function, memory, all of that. So it's all really critical to have all 3 elements.
Interesting. So exercise, and then we've already talked about diets a little bit. You mentioned the Mediterranean diet, but there's also diets maybe you could comment on. There's things called a DASH diet. I know there's a MIND diet. What are these diets? Are they worth looking into?
Yeah, the DASH diet, my sense of it is they're both modifications of the Mediterranean diet. The DASH diet is really designed to fight hypertension. It has a major salt component to it. And the MIND diet kind of combines the DASH diet with the Mediterranean diet, essentially. But it all comes back to you're not going to do well eating a couple of Big Macs a day and some fries. You really need to move into much more omega-3s, and that means fatty fish and omega-3 supplements and all of that sort of thing. I can't overemphasize the effect of DHA, which is one of the 2 major omega-3 fatty acids.
Yeah, let's jump into that, because that brings us to sort of this supplements play, right? This is, I think a lot of people would like to know, well, okay, I'm exercising, I'm trying to stay healthy, but again, when you're talking about offense, sometimes some of the things that we can add via supplements. You mentioned DHA, and then there's EPA. So maybe talk a little bit about what EPA, DHA are, and how they might be helpful.
Sure. So docosahexaenoic acid and eicosapentaenoic acid are.
That's impressive, John. You said those very big biochemicals.
Yeah, you got to learn a few things, Buck, when you're in this business. So they're both omega-3s as opposed to omega-6s. So you can actually measure this stuff with an omega-3 index in the red blood cell. And that'll give you like 120. That's about how long the red blood cell lasts or lives. Gives you 120 days back of how good your DHA is. EPA does have some effects, but they're much less important than DHA in the brain. And there's two ways for DHA to get into the brain. One is just diffusion, and that can break down a little bit. Real early on, you start to have blood-brain barrier abnormalities. This might be 10 or 20 years before you have clinical symptoms. Mm-hmm. And then you've got glucose hypometabolism. So glucose isn't really getting into the brain very well either, real early, especially in the ApoE4 people. So the second mechanism is to take the phospholipid DHA and transport it into the brain. And this DHA is amazingly anti-inflammatory. Oxidative damage is way less. You increase glucose transporter. The main transporter of the brain is called the GLUT1 transporter system. You increase that by about 30%, and you really reduce alpha-beta aggregation. So memory, neurogenesis, plasticity, blood flow, all improves. The Framingham study looked at the highest quartile versus the lowest quartile, and they had a 47% reduction in all-cause dementia. Now, remember, these are association studies. They're not prospective studies. Yeah. So other things can be going on in those people that really have high DHAs. They're probably living better in general. But still, kind of directionally, it's helpful to know that. So, and you may want to even, the phospholipid side of the DHA comes in krill oil and fish roe. You may even want to cover your bases if you're going to do a supplement and take a regular omega-3 and some krill oil. Both of those, or you can just measure your omega-3 index, with the red blood cell. We have a whole program now where we're looking at risk factors and brain optimization, and the red blood cell omega-3 index is really, really important in that. Because it looks like it's just such an important thing for brain health.
At some point, I want to get you back on for that brain optimization.
Yeah, we have some interesting ideas. It's that's a little bit out of the scope of this discussion, but
yeah, for sure. Other than the DHA, what are some of the other supplements that listen? The problem with the supplement industry is, of course, this is an unregulated industry. It's an industry that's a multi-billion-dollar industry where, especially now, everybody's all about longevity. Everybody's out to make a buck. But there are some things that have some decent data.
Yeah.
What other things would you like to maybe bring people's attention to outside of DHA?
Yeah, so I've got a big six, and there's two tiers of that. My first three that I really feel strongly about, that everybody probably should really be on, is vitamin D. We haven't touched on that very much yet.
Uh-huh.
So vitamin D, and as you might imagine, omega-3s, as we have discussed. But the third one is magnesium, and magnesium in a specific form as the L-threonate, because that's the only one that really.
So like Magtine, is that?
Magtine is another name
is
for
that
it. Right,
commercially?
right. That's the only one that really gets up in the brain, and there is some great data on synaptogenesis, so better connections between nerve cells. And probably neurogenesis as well with magnesium. And magnesium is it's a cofactor for energy production in the brain. So you need it to bind to an ATP molecule. Adenosine triphosphate is your major kind of energy system in the whole body. You need magnesium to optimize that system. And that the one magnesium molecule binds to an ATP. So if you look at the population, and it's very hard to measure this because blood levels of magnesium, even red blood cell levels, don't really tell you what's happening in tissue very well, but probably at least 50% of the population is to some degree magnesium deficient. And it's very hard to know you're magnesium deficient. So I think those three supplements really probably should be looked at by everybody, and they make just a huge difference.
DHA, vitamin D, and this magnesium type of magnesium, that Magtine would be one of the things to remember. So those might be your top
those
three.
Those are the top three, yes.
Okay. Let's
then
go to the next tier.
Probably still pretty important, is your B complex. So then we have B complex, and we have something called theracumin, or theracumin really, which we can talk about a little bit. It's really derived from an Indian spice, turmeric. And the third one that maybe is the weakest, but I think still has enough data to look at, is creatine. Yes.
Creatine. Interesting.
Yeah.
How about cocoa flavonols?
Yeah, the flavonols are very interesting as well. And the flavonols, well, there was actually one study that looked at 1 to 2 servings, which is not huge, just of blueberries and strawberries a week. And there was a significant reduction in, or an increase in brain health by reducing what they call brain aging by about 2.5 years. So those have anthocyanidins, which is a form of flavanol. I mean, there are other things that have the flavonoids in them, like green tea and apples and things like that, but probably blueberries and...
There's some supplements too.
Oh yeah,
there's
sure.
Like
there's supplements too, where
type.
where you can get anthocyanidins in for sure. But really, I mean, if you can take in a couple of servings of strawberries and blueberries a week, and that's a pretty easy thing to do for most people. Why not?
Sure.
You know, it's all this stuff that helps around the edges, right? If you've got your major kind of risk factors under control, why not just kind of try and optimize things?
Yeah. Let me ask you a question. I get asked a lot, John, because I do talk about being on. It's funny. Literally the only supplement you mentioned there that I wasn't taking regularly was creatine, but which maybe I should. But the question I get frequently from people are, okay, well, maybe I should do this, but like, where do I start? Like, how do you choose? And I'm not asking you to tell us brands, but when you would, if you have a patient who says, well, how do I know which brand to take or how much to take? What do you tell them? Because obviously we don't really,
Right. So what I tell them is, and this is a shameless plug for consumer labs, and I have no financial interest in consumer labs, but for, I don't know, I think it's pretty inexpensive, $10 or $20 a year or something. They actually independently test, because this is really important, because you do not want, like just the fish oil thing. If you get a bad fish oil, you can have a bunch of mercury in it, actually toxic metals. So you really want to vet whatever specific brand you are talking about taking through some kind of legitimate platform. And Consumer Labs does a nice job. They tell you, they have 3 or 4 recommended brands that have the appropriate amount of the supplement and no contaminants. And then they'll give you a little blurb of the data what those
Yeah.
what those should be doing, and so
Yeah. It's funny. I've mentioned Consumer Labs a few times because I use the same thing, and they do really do a good job of, breaking down not only, by purity, by, cost analysis and all that. Hopefully they'll hear us talking and eventually they'll sponsor the show, John. But right now, neither one of us are getting paid for that.
Here it
Consumer
is.
Labs hear us loud and clear. And the other thing is dosing. The dosing is always tricky. I mean, if you look at even, an example would be so many people on, not for Alzheimer's, but for in longevity, the space are either on the NMNs or those types of things for NAD. And, when you look at the bottles, they're telling you to take maybe 2 a day, but any research is done on there is like more like a 5 of them per day. So general rule for people, how do you approach that kind of thing where you're like, well, how much
usually,
do I take?
We do have some specific recommendations for our patients where we're really looking at all these different factors. But really the best way, I think, is to go back to the original papers or the meta-analyses and say, okay, here's an effect that we're after. What did it take in that patient population to achieve that effect? So yes, you're right. A lot of times, like even the amount of DHA in a supplement, I think is way lower than it really should be. A lot of times the EPA is much higher than the DHA levels in most supplements. But you don't want to just trust what it says on the bottle, and you don't really want to trust the bottle until you've vetted it. And the third thing is you don't want to start 2 supplements at once, because then if you have a problem, you don't really know. It's like anything. It's like taking 2 medications, prescribed medications at once. You want to kind of do it one at a time.
Apart from so any other supplements?
Well, those are the 6 that I really think and I'm more focused on kind of neural optimization, right? Brain best performance of the brain. There are a number of other supplements that are probably reasonably vetted to be on, but those are the 6 that I think are the most important for brain health.
And so for neurooptimization as well? Are those the same
so
that you
for
would use?
Neurooptimization as well, yes.
Interesting. Okay, cool. A few other things to just, maybe they're not supplements, but big data in terms of, at least in the finished studies on sauna and Alzheimer's. Why in the world would being in the sauna help prevent Alzheimer's, or do you think that's just like a exercise type mimetic?
There's one big study in the field. Of course, the Finns are all into this, right? The Finns like saunas. In fact, their comparative group was 1 sauna a week, which would be like nothing to them compared to the.
Right.
Yeah, I couldn't find anyone that wasn't doing 1 sauna a week. So somehow sauna is just part of their lives. The people that were high sauna people, the 4 to 7 a week, definitely had, and they followed these people over 20 years, and they were claiming there was a 2/3 reduction in moving to Alzheimer's disease versus the non-sauna people. But again, not a controlled prospective trial. Are the people that do a lot of sauna, are they in there with other people saunaing, and there's more social connection during their sauna time? I don't really understand mechanistically exactly about sauna. And I know there's some data. I'm not that up on all of the ancillary sauna data, but I think it's a reasonable thing. I mean, it's not a harmful thing, right? If you have access to a sauna, maybe it's a reasonable thing to be doing it on a regular basis.
The way I think of sauna in this is, and maybe it's wrong, maybe it's right, I don't know, but for one thing, I think a lot of the effects are probably related to the same effects that you get from exercise, really from increased cardiac output. And, you're effectively you're doing a mild to moderate, or maybe even moderate to heavier cardiovascular exercise for some people. And then maybe there's some role of heat shock proteins and
reasonable
that kind of thing
suppositions
as well. But yeah. Your thoughts on, you were talking about in terms of cognitive reserve, right? You were referring to brain games type things that you can do that sort of use your brain. Do you think that there really is something to that? People doing Sudoku or some of these games.
Yeah, no, the more cognitive complexity you can put in your life, the better you're going to do, especially when you're retired. Because now you've gone from 40 hours of maybe moderate to high complexity to a much different lifestyle. And, we have a little bit of data. There's that impact study using that brain fitness program. They did for a couple of months, an hour a day for 5 days a week. And they saw a difference in memory and attentional things even after that short couple of month period. I think one message to really impart is the brain has more plasticity than we think it does. And again, it's that analogy of, pumping iron and building up muscle, hypertrophy in the muscle. I think that there's something to be said about that, and just however you can increase complexity into your life, cognitive processing complexity is there's no ceiling effect to that. It's like exercise.
Yeah. Shifting a little bit different from that, the one other thing I want to talk about, I guess, in sort of this same space of being able to actively play offense, the last thing I'll mention is brushing your teeth. Tell us why that might be important.
Now, and again, this data is kind of contaminated a little bit by the fact that people losing their teeth
no
and
pun
not
intended.
doing good oral hygiene maybe are not doing some other things as well. But chronic inflammation is probably a big culprit. And, we didn't talk a lot about inflammation, but inflammation is probably a core issue in Alzheimer's disease. I mean, we know that it involves the resident immune cells in the brain, and that you really want to have your inflammatory markers under control. There's something called a high sensitivity C-reactive protein, myeloperoxidase, ferritin. You want all of those things pretty well controlled. Homocysteine, you want that well controlled too. So if you have poor oral health, your risk of going on to higher levels of Alzheimer's is not insignificant. I can't remember the exact number, but there's definitely an effect. But again, people that are losing their teeth and having poor oral hygiene probably fit into that lower cognitive reserve pool too, and we don't have good prospective studies.
The inflammation thing is really interesting to me too, because when I first started doing this podcast, it wasn't that long ago, John, but one of the things that kind of sort of interested me was that everywhere you turn, people were talking about inflammation. Inflammation was ultimately, it seemed to be the new buzzword across the board. Like the thing that causes everything to go wrong is inflammation. And I thought it was a joke at first, but the more I'm learning about it, the more it just as an example, I don't know if you followed this study. I saw the study in the cardiology literature that showed that to your point about HSCRP, one of these markers for inflammation, that actually is a better indicator, an elevated HSCRP of cardiovascular death of that than predictive value than LDL
I'm not surprised
levels,
by that, Bob.
which I just thought was crazy.
This inflammaging kind of, they're combining inflammation and aging. That's a real thing. So at the endothelial level, and I'm sure this is also true. Probably I don't know in the cardiac vasculature, but in the brain, you kind of change the phenotype of inflammation to a higher level as you age. So this might be part of the changes that go on that make you more prone to Alzheimer's disease. So what happens is in normal aging, you have about 10% parasite loss, which is one of the supportive cells of the small capillaries and the endothelium. And as you change to a more pro-inflammatory phenotype, you have more pro-inflammatory, what are called cytokines or proteins floating around there. And then one of the biggest, I think this came out of Stanford. I mean, we've known it for a while, but this soluble vascular cell adhesion molecule 1, or SVCAM1, is basically upregulated in the endothelium. And its role is to take immune cells from the bloodstream and put them into tissue. And so we know you don't want rising SVCAM1. And you can measure that. That's another inflammatory marker.
I wonder if, I'm just curious on this because, in the cardiology literature, the intervention that has sort of is relatively new is using colchicine.
I don't know.
Has there been any
literature on that? I don't know that I've seen literature as far as Alzheimer's and colchicine. I know though. I mean, the basic things will bring down inflammatory metrics like losing weight and getting your insulin under perfect control. I mean, really, if you're trying to optimize things, you should have a hemoglobin A1C more in the realm of 5 than 5.7. So, all of the inflammation, though, I think you're right. We are realizing that it's way more important than we thought it was in the past.
I know I've been keeping you here for a long time, but there's one more thing I think to round this out. And that is, we've talked about, okay, what is Alzheimer's? How can we potentially prevent it, play offense against it? But now there's some people who've got it or definitely going to get it before we've got, and maybe you're past the point of prevention. What is the latest when it comes to that? Because I know this is your area, right? This is what, you're in, do this, you're in the cutting edge of this. Tell us what the latest is on the treatment of Alzheimer's disease.
Now, this is not to denigrate in any way the preventive strategies and the risk modification strategies, which are super important. But we now have 3 drugs. Well, two are approved, aducanumab and lecanemab, and a third, donanemab, is
what are those
on
called?
the way. These are all what we call monoclonal antibodies. So we're taking kind of natural antibodies and we're globbing onto it something called a CDR, a complementary determining region, and we are making an antibody which is incredibly effective at removing amyloid plaque. Now, the question is, remember earlier on I said it's not just about the amyloid plaque or the tau tangles, it's the kind of the interaction with the immune system and levels of inflammation and all of that, and microglial activation. So that's what makes it a little challenging. And some of the earlier studies using other drugs similar to this have done it in very advanced Alzheimer's populations and not shown any effect.
Okay. So the idea is, so now you have a drug that might be able to, let's just use the word dissolve these plaques. that we think are part of what you at least need to have them in order to have Alzheimer's disease. The question is, does that do you any good once you already have the disease?
Yes, that's the question. And so I will concentrate on donanemab because I think it has the most impressive disease. Overall, it showed a 35% slowing over 18 months, and almost half of the patients in their, what they call their Trailblazer study, had no progression at a year. Now, these were much earlier, moderate patients. Really, you want to get people in the earliest stages, very early mild cognitive impairment. That's called MCI, which is the pre-Alzheimer's stage. If you can do that, you probably are going to even have better data than what they got working with an early Alzheimer's group. So really, there might be 50 million people in this country with mild cognitive impairment. So this is just a huge thing, and this was probably one of the reasons that Medicare was very nervous about even approving this class of drug. They've gotten so much pressure now, with sort of approving it now, but still with some restrictions. So this will be really fascinating. But I think if you can identify people early, and we can now, we didn't really talk about the blood testing very much, but there are now blood testing markers or metrics that can point you in the direction of increased plaque without having to do a PET scan, which, still nobody will pay for it, and it's really not a practical thing to do. So if we have blood markers, and we have MRI, and the people that have high amyloid risk go on to maybe having a spinal fluid evaluation, and we can do that real early, we may really be able to change the trajectory of this whole disease.
Can you explain, you mentioned one study. Tell me a little bit about more of that study where you said that there was no, at what level were those people who did not progress after
they all had moderate levels of tau protein, so not real high risk. So remember, you get your beta amyloid 42 is kind of the first step in the process. Then it impacts the neurons themselves and starts to raise your tau levels. So, and that kind of gets excreted into the system. So you can measure that, and so,
did they have clinical disease?
They had clinical
at all?
Disease. I think some of them did have sort of later MCI, but probably I think most of them had mild clinical Alzheimer's. Yeah.
So when you talked about basically being able to put, sort of stave off a progression after a year, both clinically and
some of the plaques disappeared,
one or the other,
and that's why, because they were able to say, "Hey, we're going to stop treatment after a year," because they were, this is a big pharma study. They were using the gold standard, which is doing PET scans, amyloid PET scans, and there were people in that study where there was no discernible amyloid. So yeah, that's a big deal. And it's going to be really interesting. Now, these things are not without their complications because amyloid is also found in the lining of the blood vessel. And these are very potent anti-amyloid drugs. So you can get this amyloid-related imaging abnormality called ARIA. You can either swell the brain or make it bleed. And obviously, this is another issue. The people further down the road with Alzheimer's really shouldn't probably be on these drugs. They're really for, I think, optimally the very early mild cognitive impairment group. But I think they still can be used in early Alzheimer's. But again, that's why it's so important to get assessment and early diagnosis and know your genetics.
Yeah. This is absolutely fascinating stuff, John. and I know you and I talked about, and I really want when you're ready, and not have some more time for me to talk about neuro optimization in the future. But just briefly, what are you doing with that? That's an area, obviously, a lot of people. Hey, I want to
neuro optimize. I like that, Buck. Yeah, exactly. Well,
right. I could use some neuro optimization.
It's just been frustrating for me to see that we haven't really had a comprehensive way to evaluate patients along all of these metrics, which include neuromuscular metrics and cognitive metrics and blood-based biomarker metrics, and really look at all of these different domains we've been talking about that impact risk. And so we have things like neural nutrient index. Where are you on your neural nutrients? Because we can see that in the blood, and we get some diet, patient-reported outcomes types things. We directly assess neuromuscular issues. So one thing we didn't talk about are the precursors even of MCI. Grip strength is a great precursor, and finger tap speed. Because there are early, very mild muscular things that happen before you get into MCI. So sleep fragmentation, the finger tap testing, gait slowing, and grip strength are all things that can be measured. So we're hoping to be able to capture people even before they have any cognitive changes. And the other thing is, it's not just about Alzheimer's, it's about how can you make the brain function better, even if it's not on an Alzheimer's trajectory. And we know a lot about how to do that. So we have about 75 metrics. We have a machine that gives us a fat mass and lean body mass. We're also concerned about sarcopenia. We don't want people losing weight. This big thing with the GLP-1 agonists now, everybody seems to be on Ozempic or their kin. You lose 50 pounds, you probably are going to lose 15 to 20 pounds of muscle if you don't do it right. And that you won't get that back if you're over 60. We're very tough to do. So putting all these factors and then taking them together and using some of these artificial intelligence pathways now, like phenoclustering techniques, where we can actually look at which factors seem to cluster together and use bigger populations of people that we're evaluating. We kind of hope to have sort of a neural optimization laboratory kind of seeing if we can just get people to a better level. Because the other thing we didn't talk about is just brain atrophy. The average brain atrophy, not MCI Alzheimer's, is 0.5% a year over age 60. That adds up, and so if you have some memory problems, you're more at 1%. And Alzheimer's patients are losing 3% a year of their brain. So we don't want that, and that 0.5% is an average. So how can we bend the curve to minimize that atrophy progression? Those are the kinds of things that we're really interested in.
Absolutely fascinating as usual, John. It's always great to talk to you, regardless of whatever we're talking about. And I want to just thank you again for being on. And
we have to have another session, Buck, because we've got a lot more on these little kind of neuro hacks for optimization.
For sure.
All right, great to be with
John.
you. Thank you so much, Buck. We'll see you.
Great to be with you.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.